All right, class, let's dive in right where we left off. Clinical manifestations. Patients with HIV or AIDS can experience a wide range of symptoms, and those symptoms can come from three main sources: the disease itself, the side effects of treatment, and other medical conditions they may have on top of it, like pancreatitis, hepatitis, or cardiometabolic issues. And I want you to think beyond the textbook. These symptoms aren't always dramatic. Sometimes they're subtle, chronic, and exhausting. Things like persistent fatigue, chronic diarrhea, significant weight loss, and peripheral neuropathy. Some of these symptoms linger long-term. Some flare up and fade. You'll also see dermatologic problems, dry skin, rashes, fungal infections, which may seem minor at first, but can cause a whole lot of discomfort in someone who's already worn down physically and emotionally. And speaking of emotional toll, that part is real. This is a disease that doesn't just attack the immune system, it affects the whole person. Their energy, appetite, mood, sense of identity, and relationships. The stigma around HIV still exists. Don't underestimate the impact that has on a person's ability to cope and thrive. Planning and goals. So what are our goals when caring for someone with HIV or AIDS? We want to see improvement in nutritional status. We want to reduce feelings of social isolation. We want to help the patient move through the grieving process in a healthy way. We want them to understand their illness and their treatment. And we want to prevent complications before they start. Simple? No. Important? Absolutely. Nursing interventions. Let's start with nutrition. Now, y'all know HIV can really knock out a person's appetite, and some of the meds cause nausea or taste changes. Then there's the issue of chronic diarrhea or inflammation in the mouth and throat that makes eating painful. So what do? We monitor weight. We track intake. We check labs like albumin, transferrin, and total protein to catch malnutrition early. If food intake is low, we assess the barriers. Is it financial? Is it emotional? Is it physical discomfort? We involve dietitians. We recommend calorie-dense, protein-rich foods that are easy to eat, smoothies, soft foods, soups, with added protein powder. And we encourage good oral hygiene before and after meals. Small changes can make a big difference. Decreasing social isolation. This one's important, and it's often overlooked. A lot of people with HIV experience isolation, from family, from friends, even from healthcare workers who still treat them differently. And some of them isolate themselves to avoid rejection. So how do we help? We start by educating both the patient and those around them. HIV doesn't spread through hugs, sharing food, or touching the same surfaces. Clear education can reduce fear and rebuild connection. We also assess for signs of depression, anxiety, or withdrawal. If the patient stops answering phone calls, skips appointments, or just seems off, we don't let it slide. We check in. And if needed, we refer them to mental health services, support groups, or peer networks. Human connection is medicine too. Coping with grief. Let's be honest, a diagnosis of HIV often comes with grief. Grief for what was lost, what might have been, and what could still be lost. Some patients are grieving old relationships. Others are grieving their health, their independence, or their sense of control. Some are angry at themselves, at a partner, at life. We don't rush them through it. We don't tell them to stay positive. We make room for the sadness. We encourage expression. We help them name their losses and start processing them. Sometimes just listening, really listening, is the best care we can give. Improving knowledge, education is everything. And I don't just mean handing out a pamphlet. Patients need to understand how HIV works, how it's transmitted, how it's treated, and what their role is in staying healthy. They need to know how to take their meds correctly and what side effects to watch out for. We teach about safe sex practices, needle hygiene, hand washing, and how to safely handle body fluids. If they live with others, we help set up guidelines for things like disinfecting kitchen surfaces and bathrooms, cleaning up after pets, and avoiding exposure to people who are sick or freshly vaccinated with a live virus. And again, we do this without judgment. Our tone matters just as much as our words. Monitoring and managing complications. Now we shift into the clinical side. Antiretroviral therapy, ART, is the main treatment, but it comes with a whole list of potential complications: liver damage, kidney injury, hematologic problems, and metabolic issues. So we monitor closely. We draw labs regularly. We review meds at every visit. We watch for peripheral neuropathy, nausea, fatigue, or changes in cognition. We also assess for HAND, HIV-associated neurocognitive disorder. It might show up as forgetfulness, slowed thinking, or poor concentration. We establish a baseline and reassess over time. Another complication that deserves attention: body image. Some meds cause lipodystrophy, a redistribution of fat that can change the shape of a patient's face or body. These changes can be distressing. They're visible, and they can fuel isolation and self-esteem issues. So don't brush it off. Address it with care. Promoting home, community-based, and transitional care. Most of our patients aren't living in hospitals. They're at home, they're in communities, and their support systems vary. So we teach a lot. We teach patients and caregivers how HIV is transmitted. We teach how to use gloves, how to clean surfaces, how to wash hands properly. We talk about symptoms to report and how to store and administer meds. We make sure caregivers know how to manage side effects, how to dispose of sharps, how to protect themselves without creating unnecessary fear. If there's enteral or parenteral nutrition involved, we teach how to give it safely. If meds are complicated or expensive, we connect patients to programs that help. We are teachers, connectors, and advocates. Continuing and transitional care. Let's say the patient can't work anymore, or can't drive, or is losing independence. That's where community programs and transitional care services step in. There are nonprofits and local agencies that offer transportation, home-delivered meals, therapy, even support for caregivers. We help families navigate these systems. Home health nurses play a big role too. They can assess adherence, check for new symptoms, reinforce what's been taught, and provide wound or respiratory care. And when the time comes for hospice or end-of-life care, our role becomes even more sacred. We support dignity. We encourage honest conversations. We manage pain and symptoms with skill and compassion. And most of all, we stay, even when others pull away. Evaluation. Now let's wrap this up with what we're evaluating for. 1, does the patient maintain adequate nutrition? 2, are they feeling less isolated? 3, have they made progress through the grieving process? 4, can they explain their disease and treatment? And do they participate in their own care? 5, are we preventing complications? That's how we measure success, not perfection, progress. And when you walk out of this classroom and into someone's home or hospital room, remember, you're not just treating a disease, you're caring for a human being in the middle of something incredibly complex. So show up fully, with your knowledge, yes, but also with your heart.